Spirometry, Part -1, Basic. Dr. Jalal, Mohsin, Uddin. M.B.B.S. D.T.C.D. F.C.P.S, Pulmonology. Index. 1. What is spirometry? 2. Indications of spirometry. 3. Monitoring of patient. 4. Spirometer and its parts. 5. Preparation for a spirometry test. 6. Contraindications of use of spirometry. 7. Key informations for patients. 8. Procedure of spirometry. 9. Graphs in spirometer. 10. How will you get a good spirometry report? 11. Parameters in spirometry report. 12. Complications of spirometry procedure. What is spirometry? Spirometry means measuring of breath. It is the most common type of pulmonary function tests, F.C.P.S. It measures lung function, specifically the amount, volume, like FVC, and speed, flow, like FEF 25 to 75%, of air that can be inhaled and exhaled. Spirometry measures three things. 1. How much air one can breathe in, inhale. 2. How much air you can breathe out, exhale. 3. How fast one can exhale the air from your lungs. Spirometry assesses the integrated mechanical function of the lung, chest wall, and respiratory muscles. Indications of spirometry. A. Diagnostic to evaluate symptoms, signs and abnormal results of laboratory tests for the presence of asthma, COPD and restrictive lung disease. Symptoms, presence of cough, dyspnoea, wheezing, orthopnea or chest pain. Signs, features of hyperinflation, prolonged expiration, cyanosis, chest deformity, wheezing or unexplained crackles. Abnormal results of laboratory test, hypoxemia, hypercapnia, polycythemia or abnormal chest radiographs. Indications of spirometry continue. B. To measure the effect of disease on pulmonary function. For example, lung function status after post-pulmonary tuberculosis. C. To screen persons at occupation, risk for pulmonary disease. For example, silicosis. D. In smokers to assess pulmonary function status. Indications of spirometry continue. E. To assess preoperative risk. For example, before lobectomy operation of lung. F. To assess prognosis of disease. For example, to assess the severity of IPF. Monitoring of patient. G. Monitoring of patient. 1. To assess effectiveness of therapeutic intervention. Example, A. After giving bronchodilator therapy. Example, B. To see steroid treatment response for asthma, interstitial lung disease, sarcoidosis. Monitoring of patient continue. 2. To monitor people exposed to injurious agents. Example, exposure to chemical agents. 3. To assess patient as part of a rehabilitation program. 4. To assess people wishing to undertake high-risk activities. Example, scuba diving. 5. To assess risk as part of an insurance evaluation. 6. To assess individuals for legal reasons. Spirometer and its parts. Spirometry is performed by using a device called spirometer, which is a small machine attached by a cable to a mouthpiece. The basic components of a spirometer are the mouthpiece, a tube and an electronic device to measure flows and calculate spirometry parameters. Preparation for a spirometry test. One should not smoke 24 hours before a spirometry test. He or she also need to avoid alcohol that day as well. Eating too large of a meal 2 to 4 hours before test could also impact on his or her ability to breathe. One should not wear clothing that is so tight that it could restrict his or her breathing. Avoid vigorous exercise 30 minutes before the test. Preparation for a spirometry test continue. Doctor may also have instructions, mainly for diagnostic purpose of asthma and COPD, about whether you should avoid using inhaled medications, SABA, LABA, LAMA, or oral medications, salbutamol, theophylline, doxyphylline, should be stopped prior to the test. Do not use inhalers or tablet containing salbutamol, terbutaline, ipratropium for 6 hours before the test. Preparation for a spirometry test continue. Do not use seretide, salmeterol, Symbicort, formoterol for 12 hours before the test. Do not use glycopyrronium, Seebri, Altipro, Onbrez for 24 hours before the test. Do not use tablet theophylline or doxyphylline for 24 hours before test. Contraindications to use of spirometry. Uncooperative patient and severe dyspnoea. Infectious diseases, TB, and hemoptysis of unknown origin. Pneumothorax. Recent myocardial infarction or unstable angina. Acute disorders, for example, vomiting, nausea, vertigo. Recent abdominal or thoracic surgery. Recent eye surgery, increases in intraocular pressure during spirometry. Thoracic aneurysms, risk of rupture because of increased thoracic pressure. M.B.B. spirometry should be avoided after recent heart attack or stroke. Key informations for patients. When patient reached spirometry room, following informations are collected. Height, weight, date of birth or age, self-identified race, gender at birth. Following diagram is showing that increasing height is associated with increased lung volumes. Key patient information continue. These information are entered into the system of spirometry. Computer automatically generate a predicted value of various parameters, example FVC, FEV1, and ultimately compare it with measured actual parameters of patient. A fixed percentage above and below a predicted value to be the normal range. This is 80 to 120% of predicted for FVC and FEV1, although a wider range is found for other parameters. How spirometry report vary by patient's basic facts. Sex. For a given height and age, males have a larger FEV1, FVC, FEF 25 to 75% and PEF, but a slightly lower FEV1, FVC. Age, FEV1, FVC, FEF 25 to 75% and PEF increase, while FEV1/FVC decrease, with age until about 20 years old in females and 25 years in males. After this, all indices gradually fall. Height. All indices other than FEV1/FVC increase with standing height. Ethnic. Caucasians have the largest FEV1 and FVC than other ethnic groups. Indians about 10% lower than matched Caucasians groups. Procedure of spirometry. A spirometry test usually takes about 15 minutes. Here is what happens during a spirometry procedure. 1. One should be seated in a chair in an exam room. A doctor or a nurse places a clip on his or her nose to keep both nostrils closed. They also place a mouthpiece in his or her mouth. Procedure of spirometry continue. 2. Seal lips around the mouthpiece. 3. Inhale rapidly and completely full or until unable to inhale any longer, to total lung capacity TLC. 4. Pause less than 1 second. 5. Blow air into the mouthpiece as fast as possible until completely empty, or until unable to blow any longer to residual volume, RV. Vigorous verbal encouragement is essential for the patient to continue to exhale to the end of the maneuver, example keep going and keep going. Procedure of spirometry continue. He or she should repeat this test at least 3 times to make sure that the results are consistent and acceptable. The doctor or nurse may repeat the test more than 3 times, usually not more than 8 blows are required. If there is a lot of variation between the test results, they will take the highest value from 3 close test readings and use it will be final result. Graphs in spirometer. Due to effective blow, most spirometers display the following graphs, called spirograms. 2 types of curves are produced. A. Volume time curve. B. Flow volume curve. 2 types of curves. A volume time curve, showing volume, liters, along the y-axis and time, seconds, along the x-axis. A flow volume curve, which graphically depicts the rate of airflow on the y-axis and total volume inspired or expired on the x-axis. It consists of 2 loops. A. Inspiratory loop, below the x-axis. B. Expiratory loop, above the x-axis. Flow volume curve. The normal expiratory portion of the flow volume curve is characterized by a rapid rise to the peak flow rate, followed by a nearly linear fall in flow as the patient exhales toward RV. The inspiratory curve, in contrast, is a relatively symmetrical, saddle-shaped curve. Volume time curve. The normal volume time curve has a rapid upslope and approaches a plateau soon after exhalation. The maximum volume attained represents the forced vital capacity, FVC. The volume attained after 1 second represents the forced expiratory volume, FEV1. How will you get a good spirometry report? A. Meet the acceptability criteria for FVC. B. Meet the good blow acceptability criteria. Achieve 3 acceptable blows. C. Meet repeatability or reproducibility criteria. Determine largest FVC, largest FEV1 and sum of FVC plus FEV1. D. Interpret the spirometry report. A. Acceptability criteria for FVC. 1. Smooth continuous curve, free from artifacts, such as cough in the first second. 2. Good start of test. Extrapolated volume less than 5% of FVC or 150 meters L. Time to peak flow, rise time, less than 120 meters S. 3. Good end of test. Reaches plateau at 1 second, no further volume exhaled despite continued expiratory effort. Or reasonable duration of effort of exhalation. Minimum of 6 seconds. Optimal duration of effort 10 seconds. But exhalation longer than 15 seconds will rarely change clinical decisions. Footnote: extrapolated volume. The spirometer makes a measurement called extrapolated volume to determine whether a hesitation is excessive. The extrapolated volume is unacceptable if it exceeds 0.15 liters or 5% of the FVC, whichever is larger. B. Good blow acceptability criteria. For each blow following criteria should be met. For each blow following criteria should be met. 1. The start and end criteria for FVC should be met. See the acceptability criteria for FVC. 2. Observe that the patient has understood instructions and well with following characteristics. A. Maximum inspiration. B. Good start. C. Smooth continuous exhalation. D. Maximal effort. Good blow acceptability criteria continue. 3. There should be no evidence of A. An unsatisfactory or hesitation start to expiration, extrapolated volume. B. Cough during the first second of blow. C. Cough that interfere in accurate measurement. D. Early termination of expiration, less than 6 seconds. E. Any leakage of air during blow. F. Any obstruction in mouthpiece. G. an extra breath being taken during the blow, variable effort. H. Glottis closure or hesitation that causes a cessation of airflow. C. Repeatability or reproducibility criteria. After 3 acceptable maneuvers, if the largest FEV1 and FVC values are within 200 milliliters of each other, the criteria is fulfilled. If not, continues spirometry until criteria are met, or a total of 8 trials can be done, or the patient cannot or should not continue testing. Final report should be as follows. FEV1 and FVC reported as the largest values from any acceptable trial. Best test curve from trial with largest sum FVC plus FEV1. Other flow parameters from best test curve. Parameters in spirometry report. Common parameters measured in spirometry are 1. Forced vital capacity, FVC. 2. Forced expiratory volume in first second, FEV1. 3. Forced expiratory flow 25 to 75%, FEF 25 to 75%. 4. Maximal voluntary ventilation, M.B.B.S, also known as maximum breathing capacity. 5. Peak expiratory flow, PEF. 6. FEV1/FVC ratio. 1. Forced vital capacity, FVC. Forced vital capacity, FVC, is the volume of air that can forcibly be blown out after full inspiration, measured in liters. FVC is the most basic maneuver in spirometry tests. Approximate value in male 4.8 liter and in female 3.7 liters. Less than 80% of predicted are often considered normal. FVC equals inspiratory reserve volume plus tidal volume plus expiratory reserve volume. 2. Forced expiratory volume in first second, FEV1. FEV1 is the volume of air that can forcibly be blown out in first 1 second, after full inspiration. Values of between 80% and 120% of the average value are considered normal. Predicted normal values for FEV1 depend on age, sex, height, weight and ethnicity. Normal people can exhale more than 75 to 80% of their FVC in the first second. 3. FEV1, FVC ratio. FEV1, FVC is the ratio of FEV1 to FVC. In healthy adults this should be approximately 70 to 80%, declining with age. In obstructive diseases, example, asthma, COPD, FEV1 is diminished because of increased airway resistance to expiratory flow. The FVC may be decreased as well, due to the premature closure of airway in expiration, just not in the same proportion as FEV1. This generates a reduced value, less than 70%. In restrictive diseases, such as pulmonary fibrosis, the FEV1 and FVC are both reduced proportionally and the value may be normal or even increased as a result of decreased lung compliance. 4. Forced expiratory flow 25 to 75%, FEF 25 to 75%. The FEF 25 to 75 is defined as the mean forced expiratory flow between the 25% and 75% of the FVC, which is interpreted as a quantitative measure of small airways obstruction. An early indicator of obstructive airway disease. Normal value 4.5 to 5 liter per second or 300 liter per minute, up to 2 liter per second acceptable. Greater than 79%, normal, 60 to 79%, mild obstruction, 40 to 59% moderate obstruction, less than 40%, severe obstruction. 5. Peak expiratory flow. The peak expiratory flow, PEF, also called peak expiratory flow rate, PEFR, is a person's maximum speed of expiration. It measures the airflow through the bronchi and thus the degree of obstruction in the airways. Time to peak flow, rise time, is less than 120 milliseconds. Peak expiratory flow is typically measured in units of liters per minute, L/min closing parenthesis. 6. Maximal voluntary ventilation, MVV. The maximal voluntary ventilation, MVV, is a measure to assess neuromuscular and respiratory systems. The MVV is the total volume of air exhaled during 12 seconds of rapid, deep breathing, which can be compared with a predicted MVV defined as the forced expiratory volume in 1 second, FEV1, times 35 or 40. A significant difference between the predicted and measured MVV may indicate insufficient neuromuscular reserve, abnormal respiratory mechanics, or an inadequate effort. Complications of spirometry procedure. Spirometry is generally considered to be very safe and it rarely results in complications for patients. It can occasionally cause effects in some individuals, such as dizziness, faintness, shakiness, nausea and fatigue, but these are typically short-lived and resolve shortly after the test. But sometimes when require maximum effort may result in following condition. Complications continue. Transient breathlessness, oxygen desaturation, syncope, chest pain, cough, incontinence. Forced maneuver can induce bronchospasm in poorly controlled asthma patient. Sometimes progressive decrease in FEV1 may occur with successive blow. Thank you all. End of part 1. Learning Pulmonology.